Today we are going to discuss about birth injuries. Birth injury refers to the damage or injury to the child before, during or just after the birthing process. Birth trauma refers specially to the mechanical damage sustained during delivery, such as nerve damage and broken bones. Birth injuries are defined as impairment of the neonatal body function due to adverse events that occur at birth and can be avoidable or inevitable. Despite exact prenatal care, birth trauma usually occurs particularly in long and difficult labor or fetal malpresentations. The incidence of birth trauma has decreased over time with the improved obstetric care and perinatal diagnosis. The incidence of birth trauma varies based on the type of delivery, fetal presentation, and type of injury, and is reported to be between 0.2 and 41.2 per thousand birth. It seems that the rate of neonatal trauma will never be zero because the birth injuries will occur in the optimum condition, best obstetrical care and diagnosis, and even the absence of any risk factors. The incidence of birth trauma has decreased over time with the improved obstetric care and perinatal diagnosis. And the incidence of birth trauma varies based on type of delivery, fetal presentation, and type of injury, and is reported to be between 0.2 and 41.2 per thousand birth. We have already discussed this. The risk factors are primarity, that is a nullipara, that is a primigravida woman, that is primarity, small maternal stature, that the mother is small. Maternal pelvic anomalies, prolonged or unusual or rapid labor, or oligohydramnios. Then versions and extractions, malpresentations of the fetus, use of mid-forceps for vacuum evacuation, fetal anomalies. Types of birth injuries can be divided into head and neck injuries, nerve injuries, facial injuries, fractures, intra-abdominal injury, soft tissue injury. Now we can look on head and neck injuries. Head and neck injuries include extracranial injuries, cranial injuries, intracranial injuries. Extracranial injuries include Capit's axinum and cephalhematoma. The picture shows Capit's axinum and this picture showing cephalhematoma. In Capit's axinum, the edema is formed in between periosteum and scalp. In cephalhematoma, we can see it is below periosteum. There is hematoma formation. Next, subgaleal hemorrhage. Subgaleal hemorrhage is the hemorrhage in between periosteum and galea aponeurotica. Is newborn. It is a newborn brain bleed, that is subgaleal hematoma is known as subgaleal hemorrhage, serious neonatal bleeding complication that occurs when the blood accumulates outside the baby's skull extracranially. The subgaleal hematomas have potential to draw significant amount of blood from the newborn, putting the baby at risk for injuries including neonatal encephalopathy, seizures, or even death. Due to the high risk rate of this condition, it is crucial that subgaleal hematoma should be identified and treated promptly to avoid damage to the baby. Cranial injuries. Cranial injuries include lineal skull fractures that affect the parietal bones related to the compression due to forceps. Repressed skull fractures, inward buckling of the skull bone, to resemble the cup shape or ping pong ball shape. Surgery is needed if the CSF ran out due to brain damage. Intracranial injuries, we can divide into intracranial injury. Intracranial hemorrhage can happen. Types: intraparenchymal hemorrhage, epidural hemorrhage, subdural hemorrhage, or subarachnoid hemorrhage. Intracranial hemorrhage, we can see during vacuum extraction there will be chance of intracranial hemorrhage. Symptoms include apnea, seizures. Epidural and subdural hemorrhage. In subdural hematoma, that is, it is also, we can say it's a hematoma also. Subdural hematoma, in CT scan or MRI we can see concave or crescent shape, that is shape of a banana. Subdural hematoma, banana, sub-banana. We can remember by this mnemonic. Bridging veins will be there. Elderly, alcoholics. It's not about commonly it's not seen in LRE. In epidural hematoma, it is convex or lens-shaped. Middle meningeal artery is damaged in epidural hematoma. Lucid interval it's happening. Epi-pi, we can by this mnemonic we can remember that it is like a lemon shape, that is convex or lens-shaped. Subarachnoid hemorrhage, we can see in the picture, in between the arachnoid layer of the brain. It manifestation of seizures occurring in the second day of the life, irritability, depressed level of consciousness, focal neurotic signs. Intraparenchymal hemorrhage. Clinical features: in the preterm infant, intraparenchymal hemorrhage is often clinically silent, either intracranial fossa unless hemorrhage is square large. In the term infant, the manifestation are seizures, hemiparesis, gaze difference, irritability, depressed level of consciousness. Nerve injuries. Nerve injuries include brachial nerve plexus injury, facial nerve palsy, that is Bell's palsy, phrenic nerve injury, laryngeal nerve injury, spinal cord injury. Brachial plexus injury can be divided into Erb's Dutch knee paralysis, that is, it is also called weightless position. The injury is happening in between C5 to C6 or C3 to C6. Loses the power to abduct and external rotation and supination. Motor reflex absent on the affected side. This is Erb's palsy. It's a research abstract that who is to blame and what will happen. Erb's palsy. Erb's palsy is initially a fight. Invincible harms limbly from the shoulder with flexion of the wrist and fingers due to weakness of the muscles innervated to cervical root C5 and C6. The risk factors include macrosomia, shoulder dystocia. Erb's palsy may not occur in the cesarean section. Erb's palsy may occur in cesarean section also. It is commonly believed that caused by inexperienced clinician applying too much lateral traction during delivery. Risk of Erb's palsy markedly reduced to cesarean section, although it does occur. Klumpsky palsy, also a type of brachial injury. It involves C8 and T1. The grasp reflex is absent, but the bicep reflex is present. Flaccid extremity with the absent reflexes. You can see in this picture Erb's palsy and Klumpsky palsy. Facial nerve injury. Bell's palsy risk factor include forced delivery, prolonged second stage of labor. Clinical manifestation include weakness of both the upper and lower facial muscles. At first, nasolabial fold is flattened and eyes remain persistently open on the affected side. During crying, inability to wrinkle in the forehead. Phrenic nerve injury. Injury to phrenic nerve led to paralysis of the ipsilateral diagram. Clinical manifestation: respiratory distress. Chest radiograph, that is chest X-ray, shows elevation of affected diaphragm. With mediastinal shift to contralateral side, USG and fluoroscopy confirmed diagnosed by paradoxical diaphragmatic movement during inspiration. Treatment is initially supportive treatment, that is providing oxygen. If there is respiratory failure, we can treat with continuous positive airway pressure or mechanical ventilation. We can give the wave feedings. Laryngeal nerve injury symptoms: stridor, respiratory distress or hoarse cry, dysphagia, aspiration. Diagnosis made by laryngoscopy, direct laryngoscopy. Treatment: small frequent feedings may be required to decrease risk of aspiration and intubation. Tracheostomy. Spinal cord injury. See, at C4 level, it is called tetraplegia. At C6 level, C4, C6 tetraplegia, T6 paraplegia, L1 paraplegia. Clinical findings are decreased or absent spontaneous movement, absent deep tenor reflex, absent or periodic breathing. Management: if cord injury is suspected in the delivery, head and neck spine should be immobilized. Therapy is supportive. Facial injury: it includes nasal septal dislocation, that includes dislocation of triangular cartilaginous portion of the septum. In ocular injuries include rupture of Descemet's membrane of the cornea. The cornea has many membranes. One of the membrane is called Descemet's membrane. The rupture of Descemet's membrane of the cornea, lid laceration, high femur, that is blood in the anterior chamber, vitreous hemorrhage. Fractures include most fracture occurring clavicular fracture, most fractured bone during birth. Risk factors: higher birth weight, prolonged second stage of labor, shoulder dystocia, instrumental delivery. Management: asymptomatic incomplete fractures require no treatment. Complete fractures are treated with immobilization of the arm 7 to 10 days. Long bone fractures can also occur. Risk factors include breech presentation, cesarean delivery, low birth weight, decreased movement of affected extremities, swelling, pain, passing movement, crepitus can also occur. Intra-abdominal injuries include liver injury, subscapular hematoma may present more incidentally with anemia, poor feeding, neotachycardia. Adrenal hemorrhage may present and flank mass. Soft tissue injuries include abrasion, laceration, avulsion, incision, puncture, amputation. Petechiae and ecchymosis, laceration and abrasions, subcutaneous fat necrosis,